Hello and welcome to the IDSA Clinical Education Infectious Disease Podcast, formerly the CCO Infectious Disease Podcast. I'm your host, Kristen PharmD. Today's episode is the third of three taken from our live event on carbapenem resistance in critically ill patients. This episode covers the evolving management of S. maltophilia. I'm joined by Dr. Ryan K. Shields from the University of Pittsburgh. To follow along with the slides, please visit the show notes for this episode. Now let's get started.
Let's talk briefly now about a pathogen that is starting to gain a lot of attention. And many of you may also see this in your chronically ventilated patients, Stenotrophomonas maltophilia. So we'll wrap up talking briefly about Stenotrophomonas and give you kind of a classic case example here. This is a patient with an allogeneic stem cell transplant coming in neutropenic, and they have now a new ventilator-associated pneumonia. Respiratory cultures are only identifying Stenotrophomonas maltophilia. No other pathogens are present. And so I think a common question we ask ourselves is, well, is this really a pathogen? Is it something sticking to the ET tube? Or do we need to aggressively manage this with antimicrobials? Now, the host is really relevant here as you have a neutropenic stem cell transplant patient, certainly at risk for hemorrhagic pneumonia caused by Stenotrophomonas, which has been reported in the literature. And so this would be the kind of patient we'd probably err on the side of treating, and I think most of you would agree with that, particularly if Stenotrophomonas was the only thing we found in our respiratory cultures. Really briefly about Stenotrophomonas, what makes this bug such a nuance is all the factors you see listed on the screen here. This is a bug that's equipped with a number of intrinsic underlying mechanisms of antibiotic resistance. It has two chromosomally encoded beta-lactamases, L1 and L2. Most notably, L1 is a metallo-beta-lactamase. The combination of these two really mitigates the activity of all beta-lactams. Besides some of the options we'll talk about today, it makes a lot of efflux pumps. It has a methyltransferase, which means all aminoglycosides are intrinsically resistant. So already knowing that you're treating Stenotrophomonas, you feel a bit handcuffed because you don't have many treatment options available to you because of its mechanisms of resistance. Now, if you are looking into your literature or maybe your microbiology laboratory is reporting some of these options to you, you'll really see summaries about 4 agents that are now recommended with variable weight. Those being trimethoprim sulfamethoxazole, levofloxacin, minocycline, and cefiderocol. In fact, these are the only 4 agents that CLSI has adopted susceptibility breakpoints for. And in reviewing these breakpoints and trying to update the most recent evidence, what has become eminently clear is there's not a lot of good or high-quality evidence for the management of Stenotrophomonas whatsoever. We've largely relied on observational studies, and I'm going to show you in a minute an observational study that you may not have known it, but you probably have put some stock into in your clinical practice. So when you look at those treatment options, many of you, like myself, have probably taught your trainees over the years that Bactrim or trimethoprim sulfamethoxazole is really the drug of choice for Stenotrophomonas. In fact, many of us have done this for several decades. And in preparing this presentation and looking into this, we start to wind the clock back. Where do we start with as Bactrim being the frontline agent for Stenotrophomonas? We can go back to the 1970s, where at that point, Pseudomonas maltophilia was reported to have high levels of resistance to aminoglycosides, which we now understand why, and high levels of resistance to beta-lactams. And so Bactrim became, well, one of the few options that would test susceptible. But the clinical evidence that supports Bactrim being a frontline agent for Stenotrophomonas originates with a single case series of 3 patients. That's right. We've taught all of our trainees to use Bactrim, largely originated from a case series of 3 patients, all that had endocarditis due to Stenotrophomonas, and all of which that received Bactrim in combination with other antimicrobials, as you can see on the slide. Now, all 3 of these patients survived their endocarditis, which was a feat in the 1970s, of course, but that is the basis of the evidence for Bactrim for Stenotrophomonas. So when I say we don't have a lot of high-quality evidence for this particular bug-drug combination, this is the kind of evidence that we're talking about. So what has happened in a more contemporary studies, we said, well, if there's not a lot of clinical evidence to support Bactrim for Stenotrophomonas, what can we generate from a laboratory perspective? Well, when we start looking at Bactrim in a laboratory setting, as it turns out, even with using humanized dosing of 20 milligrams per kilogram, you actually can't kill Stenotrophomonas in a test tube with Bactrim. You're like, well, maybe it's just the drug's not working in the particular media. And so you can see in this study, they used an E. coli strain as a control, and Bactrim killed E. coli very well, but Bactrim did not kill Stenotrophomonas in a test tube. So, okay, that's really not all that reassuring. So what about the clinical evidence that's available? Well, unfortunately, the best evidence we have comes from an administrative database. Many of you are familiar with the Premier or Pink AI database. And they took observational data from that database of over 1,500 patients that had Stenotrophomonas isolated in either blood or respiratory cultures. And they compared patients who received Bactrim or levofloxacin. And here is the forest plot of that study. Now, mind you, these patients did not have clinically defined pneumonia per se. They just had positive respiratory cultures. But you can see that the outcomes favored levofloxacin for patients with respiratory cultures, specifically where there was no difference in bloodstream infections. So the accumulating evidence suggests maybe we do need to rethink this idea that Bactrim should be our first-line agent for Stenotrophomonas. And of course, many of you are well familiar with the limitations of fluoroquinolones. Well, what are our alternatives? Well, cefiderocol, as it turns out, in several large surveillance studies, has excellent rates of in vitro susceptibility. You see, greater than 98% of all Stenotrophomonas are reported as susceptible at an MIC less than or equal to 1. We also have animal model data. The figure on your left is showing you in a neutropenic mouse model that you see significant reductions in log CFUs in a thigh compared to ceftazidime or controls. And then on the right-hand side of your slide, you see a neutropenic rabbit model where 8 rabbits in each of those arms were treated with humanized dosing of either cefiderocol or Bactrim compared to control. And you see significantly higher rates of survival for those rabbits that received cefiderocol. So where does this leave us if you're putting it all together and looking at the available treatment options at your institution? Well, we've done this at my institution. These are 371 consecutive patients with Stenotrophomonas. Here's our reported susceptibility rates. These were generated by broth microdilution and triplicate. You see very high rates for 3 options, those being azacitidine, avibactam, cefiderocol, and Bactrim, where you see lower rates of susceptibility for levofloxacin or minocycline. So when you put this all together, then now you have some rationale to understand why the IDSA is taking kind of a unique stance in how we should be treating Stenotrophomonas. Their stance is you need to use combination therapy. And this goes back to what we talked about with Pseudomonas before. We don't feel like we have a preferred monotherapy. As clinicians, we have this tendency to use combinations because we're not sure if any individual component of that combination is all that effective. And that is indeed what IDSA is recommending now for Stenotrophomonas, is to use any 2 of the following you see in the blue box there, those being cefiderocol, minocycline, Bactrim, or levofloxacin, or alternatively use the combination of ceftazidime, avibactam plus azacitidine, because remember, Stenotrophomonas is a metallo-beta-lactamase producing organism, much like what you learned about with NDM earlier today. So our take-home points with Stenotrophomonas: we all recognize in this room it's a very difficult pathogen to distinguish colonization versus infection, but in the right host, it certainly does warrant treatment. And what treatment you're going to do largely depends on maybe your local clinical practice, your clinical experience, but if following the guidelines, really it doesn't recommend any therapy as monotherapy and now strongly prefers combination therapy for everyone.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. To listen to the other 2 episodes, please click the link in the show notes. To get access to all our new podcasts, subscribe to the IDSA Clinical Education Infectious Disease podcast on your favorite player. Thank you and have a great day.